Hello from Chennai. Welcome to this live inbox session. So we have an interesting case. This is a 70-year-old lady. Can you show the PowerPoint slides, please? Yeah, this is a 70-year-old lady who had come with a unstable angina. She's a known hypertensive and she's not a diabetic. And her LV function is normal. Her coronary angiogram shows a single vessel disease. Next slide. Can you move to the next slide? Yeah. The right coronary artery is normal. Next slide. So the left coronary artery, the left main is large and there is a trifurcation. There is a disease of the LAD starting from the ostium. The long lesion. It's a very tight lesion from the ostium. I can see the cranial view is a long LAD lesion involving the large diagonal. The diagonal is very large and it has an ostial lesion extending almost 8 mm into the diagonal. So essentially we have a LAD diagonal lesion which is Medina 1-1-1 bifurcation, and we have a left main which is 0-1-0-0 bifurcation. So it's actually a left main is a large one which divides into a ramus, LAD and the circumflex. This is a trifurcation. The syntax score is 11. So we discussed various options. So here we have almost like two bifurcation lesions. One is a LAD diagonal true bifurcation and a left main trifurcation. So it's a lesion which involves the ostium of the LAD. So we discussed various options, CABG versus angioplasty, and the patient wanted to have PCI. Since the syntax score was 11 and she was not a diabetic, we decided to go ahead with the PCI. So what are the options? We thought about various options. As we can see, since there is an ostial involvement and there is a bifurcation with the diagonal, if we can get a stent exactly at the ostium, it may be challenging, and so we can do with a plain old balloon angioplasty with the regulating balloon of both the LAD and diagonal, and if we can get a good result without a major flap, then it would be really good without stenting. It will give us a good result without stenting the left main. We'll have with a regulating balloon, the results will be good. But again, there are challenges to leave these arteries without stenting. So the other option we can consider is use a BVS. We can stent the LAD with the BVS and then stent also the diagonal with another BVS, 2 BVS strategy. We can use it by tap technique. But the problems with this strategy would be we will have to write starting from the ostium, and if we have to stent the left main, BVS may not be suitable because of the size limitations, and the left main in this anatomy looks quite large, about 5 mm. The other option is to consider a drug-eluting stent and do a tap for provisional with tap for the left main, and do a DK crush for the LAD diagonal. So the LAD diagonal, diagonal definitely needs a two-stent strategy because diagonal is quite significantly large. It has got a more than 5 mm length. The diagonal is involved, and also the diagonal ostium is definitely involved with a very significant lesion. So it's a 1-1-1 bifurcation. So I would definitely plan a two-stent strategy for LAD diagonal. And of the two-stent strategy, I would probably look at doing the diagonal first and then the LAD. Maybe the DK crush would be a good option. QLAT is ruled out because of the possible left main which may require treatment, and it may be a T-stenting, but the angle doesn't favor a T-stenting. So we would prefer a DK crush with two-stent strategy for the LAD diagonal, and for the trifurcation we will go with provisional, and we would do an intravascular ultrasound to look at the involvement of the left main, and if the left main is having not much of a disease, then we would treat it only from the ostium. So these are the options, and also we can have one more option with BVS where we can use a stent, do a stent to the diagonal, and and crush and get a kissing balloon and get a good result to the diagonal, and then place a BVS from the ostium into the LAD. So with these options, I would weigh and consider. I will probably start with the diagonal and do a plan a DK crush or diagonal, send the diagonal, do an intravascular ultrasound, and then you take a decision. If the left main is involved, stent from the left main to the LAD and treat it as a provisional with protecting the ramus and the circumflex. If the left main is not involved, then I would probably treat it from the ostium and then have a wire and balloon in the ramus, so to prevent the carinal shift, and to place a stent and simultaneously inflating the balloon in the stent so that there is no shifting of the carina. So these are the options. So we will proceed with the case, and then we will, as per the IVS findings, we will plan and modify our strategy. So she has been loaded with aspirin and clopidogrel, 600 milligrams, and she is on maintenance dose of clopidogrel. Our anticoagulant strategy is bivalirudin. So we have started her, given an infusion. She weighs only 48 kgs. So we have started her on bivalirudin. And our hardware, we have taken the right radial approach, she has taken the 7 French sheath. So she take a plan a 7 French guide and take a 7 French EBU guiding catheter. We would like definitely take a 7 French in this case, because we might have to do some strategies for the left main, which may involve placing multiple balloons and stents. So I would prefer to have a 7 French in place. So we will proceed to the case now. This is a 7 French EBU guiding catheter, which we will start with. Okay. We'll have to do a laocranial also. The right picture. Here down. Yeah. Picture. Yeah. Can you get a laocaudal, please? Okay. Picture. Yeah. Okay. So we have a laocranial view where we have we can clearly see the bifurcation lesion with 1-1-1 bifurcation. The diagonal appears to be quite big. Test. Going into. Can you give me a small test to see whether we are on the diagonal? See, the flow is already a little less. With 2 wires, it's becoming very less. Small test. Yes, I think so. Okay. Can you put the talker into the LED wire? So it looks like a very tight lesion, and we have wired it. It looks like a tight lesion, and there is some reduced flow in the diagonal. So we will probably have to dilate a little bit and then take the IVS. Okay. Okay. I think we will dilate the diagonal. Okay. Give me a small test. We may not get any flow. Let's see. Okay, go up. Negative. Yeah. Go up.
4, 6,
8, 10. Okay, come to caudal, please. Negative. Okay. Show. Small test. I think we will have to go to the LAO. I think looks good. Go to the LAO caudal. It's more clearer. Okay. Same LAO caudal. Give me a test. Okay, go up. Store this. Go up. 10. Oh, 1 minute. Okay. Okay, 10. 12. Negative. Okay. Okay, that's fine. Small test. That's fine. She's having pain, so maybe the IVS catheter is reducing her blood flow. So this is starting from the mid lady. We'll do a pullback quickly because she has pain. So we'll do a quick pullback. Yeah, pullback started. Yeah, bring it more forward. Yes, start. Can you show the IVS? So this is a run from the diagonal. So we will do a quick IVS run. கொஞ்சம் வலி வருமா சரியா போயிடும் 2 நிமிஷத்துல. Now show me the IVS run from the LED. Can you just run it? Yeah, we are moving from distal to proximal. I want only the IVS, please. Only the IVS. Yeah. So the distal vessel LED is quite small, and as we are moving more forward, the vessel size is gradually increasing. And can you go? Yeah, we can now see the bifurcation coming in. Now the diagonal. Then now the LED is quite big. There's a mixed block, quite a tight, significant block, and now we are moving to almost near the proximal LED. There's some calcium. We can see the calcium in the 3 to 6 o'clock position, and there's also some calcium in the 9-10 o'clock position. So long calcium. Proximal LED is quite a 3 millimeter vessel, 3.25 millimeter vessel. So, and now we can see the ramus coming in, and this is the left main, so the circumflex and the ramus. You can see the left main. The distal left main is not having much disease, some minimal plaque, and the entire left main is normal, looking normal. So the left main being normal, I think our strategy now will be we can put a stent at the ostium and not stent the left main. So that is the information we got from the IVS. So we see the distal reference here. The vessel diameter looks around 2.9 to around, so it's around 3 millimeters distal diameter, and the proximal reference diameter is around 3.5 to 4. So we probably have to put in a 2.75 stent and take it proximally a little more. The left main is huge, and we are probably not treating the left main. So let us look at the IVS from the diagonal. So that will give us a lot of information about the stent size, what we are going to choose from the diagonal. So the diagonal, this is from the distal part of the diagonal. This is looking quite small. It's only 2 millimeters, and we are moving more proximally. The vessel is gradually growing, it's a little bigger in size now. So there's a block coming. There you can see some flap with a balloon-induced flap, which we caused by our balloon dilatation. Now the diagonal appears a little more larger. It looks like around 2.5 to 2.6. There's a small calcium, and again in the 9 o'clock to 6 o'clock position. And now we are coming into the LED. So we have a diagonal which looks like around 2.5. Can you show the distal diameter? It looks very small, 2.2 to 2.3. So quite a small area, and the proximal landing zone looks a little more bigger with 2.5. So probably we can take a 2.25 stent for the diagonal. So we will take a short stent at the diagonal, and first we treat the diagonal, and then we move over to the LED. So the strategy is now DK crush to LED diagonal, and probably leaving the left main. That is the strategy now, with the IVS findings clearly showing there is not much of disease in the left main. So let us proceed with the DK crush, and we will do a stent. We will predilate the LED with a bigger balloon and use a 2.25 stent to the diagonal. So can you give me a 3 millimeter balloon to the LED? We will predilate the LED and then go ahead with the diagonal. So the steps for DK crush is we need to get a good predilatation of both the LED and diagonal. So we have already achieved a good predilatation of the diagonal. So we will also dilate the proximal part of the LED, which showed a lot of calcium in the IVS. So I would like to dilate nicely before we go ahead with the stenting. So this is a 3 millimeter into 12. This is 312 NC Trek balloon. 6, 8, negative. Okay, give me a test. Wait, we will have to do it. Again, small test. Very small test. Oh, enough. All flap everywhere. Give me a stent. See, we have now protruded the diagonal stent into the LAD. It looks like we want to do a minimal crush, so we don't want to fully into the LAD. So we have just kept it into the LAD. Make sure that it is fully covered so you don't leave in the ostium. Can you freeze it? So we keep the balloon to crush, and then we ready to crush. Deploy the stent now into the diagonal. Go up. Slowly, because only a 2.25 stent.
4.
6. 8. Just wait for some time like that. Negative. 10. Diagonal 10.
6, 8,
10.
10.
Okay. So make sure we deploy the stent very well. Negative. Now we deflate, and before we will have to remove the balloon and the wire, and make sure we don't get the LED balloon out. Okay, looks like there's some spasm. Give some NTG. Give some NTG, please. It's very important to do that very important before we take the diagonal wire out, because if there is a flap, the diagonal would close. So give some NTG to be sure the diagonal is looking good. Okay, good. Ready? Yeah, that's fine. Look, the diagonal looks good, and I'm going to remove the wire now. Can you store that image, please? Yes. Now we will remove the diagonal wire, and then we do the stenting of the LED. Okay, remove it off. Slowly, go up 4. So we are crushing the stent now, diagonal stent. Yes. 6. Okay, good. Store this, please. Negative. So we have crushed it adequately. Now let us now do a kissing now. So get the BMW back again. We will do a kissing. Get this.
2.5. 2 is already there. 215 is there.
Okay, let's get the balloon for kissing now. Okay, now let us get the LED, the other balloon. Get the diagonal LED balloon, please. Yeah, down next to the. So we are ready to do the first kissing, and so we will do the first kissing. 10. Yeah, just keep it like that at 10 for some time. 12. Okay, I think 12 the balloon is open nicely, so I'll be happy with 12. Negative both simultaneously. So let us decide on the stent for the LED. Can you store this? We will have to stent the LED, so we will have to decide on the length of the stent. So I will have to stop right at the ostium. So I will remove the diagonal wire, and then decide put the wire into the ramus. So I would like to do a 2.5 stent, and then take it up to 3 millimeter approximately, so that we don't have there is some size mismatch the distally, and I will go up with a 3.5, approximately 3 or 3.5. So can you give me now the another balloon, and we will wire this and then take another stent. Now this is the diagonal wire. I'm going to remove the wire. Okay, can you come to caudal, please? Give me a small test. Yes. Come to apicaudal now, please. I'll just place it like that, and now give me a 2 millimeter balloon. And see, the IVS looks 17. It's very, very close. I don't know. We'll take a 2.523. Yeah. Play. Okay, now give me. Wait, get the balloon negative. This one. Very small test. Into this also. Store it and show, please. I think we are okay. So let us inflate the Ramus stent. Give it to her, Ramus. You take the LED.
Sister,
Please come. Yes. Ramus balloon, correct. You have the Ramus balloon. You just go up 4 atmospheres. There's only 4. Be ready to go with the. Yeah, go up with the LED. Yeah. Go up. 6. Yes. Negative both. We would like to do a proximal optimization. Yeah, I think this is good. Now come to cranial. Can you show the stent boost? Just to be sure that we are within the stent. Yeah, it looks good. Okay. Now we'll go up. 4 in the Ramus. You take only 4. And we'll go about 8, 10. Yeah. 4. Okay, go 8, 10, 12, 14, 16. Negative. 16 negative. Both negative. 4. Just only 4. 6. Negative. Hold on. So there is some minimal pinching of the Ramus, and I am quite alright about the LED play. Can you play again, please? Looks alright to me. I will look at the IVUS again, and then we will do a final kissing. Okay, let's do the final kissing, and then we will do the IVUS. Okay, come. Can you give me a talker, please? So let's get into the LED. So at this point, it was very important to realize that the wire should cross the proximal strut rather than the distal strut, and I need the wire to be. The wire is not having free movement. Probably within the strut, if the wire is not moving freely, the wire is better now. So if there is no free movement, I know that wire is getting stuck within the stent. So this is very clear. It's in the proximal strut. Can you store this, Andrew? Okay. Now we are quite okay that we have crossed through the proximal strut. Now we will get the balloon. Please give me an N balloon. So give me a 2 millimeter balloon, or we recross it to another strut. We trying to cross it little. The strut probably it has gone to a very narrow strut and it wouldn't cross. So we will probably try to cross with another next strut, which will make it a little more easier for the balloon to cross. Other option is we can try using a smaller balloon. We can give you also 1.5 balloon, and if it goes, if it doesn't go, we can use that. Looks like this is gone down from that artery. Okay, let's try. Give me the balloon. Can you give me the balloon, Andrew? Oh. Give me a 1.5 balloon. If this is the smallest balloon you have? Yeah, it's crossed. Okay, good. So let us get that. Now this is balloon. Can you store this? Yeah, we have crossed the balloon. Now let us remove this diagonal wire out. That's right. Okay, give me the LED balloon now. That's fine, they're passing nicely. Okay. Yeah, go up 20.
16, 18, 26.
Okay, good. Negative. This you go 12. 12. 16. 18. Negative. 12.
12,
Okay, LED 16.
14, 16.
Keep it enough. Keep it like that. Enough. Negative. Okay. So we have done the second kiss, and this is the the final kiss. We have used a 2.5 millimeter in the diagonal and a 2.5 in the LED. Probably we'll use a little higher balloon in the LED. Okay, now you give me a 3 millimeter balloon. Okay, 4 both. Both 4, no? Yeah, minimal overlap. 6 both. Both. Yes, some spasm in the LED. Yeah, we'll give some NTG and show, freeze it. Okay, good. We come to levocaudal. That's fine.
Bolus, no? Sweet bolus.
Yeah, okay. So now we will have to look at the LED distal and then whether we need to do anything for that. Show nicely the distal and we see. Okay, good. That's fine. Okay. That's easy.
Because of the adventitial calcium.
Yeah, maybe let us do IVS please now. We're ready for IVS. Pressure's up now. Your distal edge of the stent is seen all right. There is no flap or no dissection, which was there's some spasm in the angiography, which is only spasm. We're very sure, and now we could the stent is very well apposed. You're all right, Mahmood. It's mudijithu. So looks quite good. The LED at that bifurcation, and now the LED looks quite big, and there is no malapposition. And now we could see the coming towards the left main, and this is the left main, and we could see the left main is all right. There is no proximal dissection, and there is one strut protruding, which is quite all right. The left main looks good. So let us look at the areas. Can you show the areas, please? Yeah. This is a distal. The area looks 4.5 square millimeters, and there is no malapposition. And this is in the mid of the level of bifurcation. The area is again looking very good. There is no malapposition and looks very good. I am quite. The result is quite acceptable from the IVIS. Crania. Okay. picture. Yeah, so this is the final picture and it looking good now. There's some little spasm which is very clear by intravascular ultrasound, and she's doing well, and we plan to keep her on ticagrelor